Dr. Urara Nagagawa is Director of Emergency and General Medicine Department of JR Sapporo Hospital in Hokkaido, Japan. She graduated from Tokai University, Japan, and started her career at the Teineke Keijinkai Hospital, where she trained in internal medicine. In the following years, while working at the Teineyama Clinic, she completed a postgraduate degree in on-the-job training and education at Hokkaido University. This learning opportunity inspired her to work on improving the working condition and environment for Japanese doctors. She then started working for Sapporo Tokushukai Hospital, one of the city's busiest hospitals and home to a highly recognized orthopedic trauma center famous in Japan. During this period, she was the only member of Emergency and General Internal Medicine Department for a short time. However, since then, many young doctors and nurses gradually joined, and it is now one of the busiest departments of that hospital. After 2 challenging years managing the hospital's COVID-19 response, she passed down the position to colleagues, and now she works at the JR Sapporo Hospital, which has more than 100-year history in Hokkaido. She's working she worked on opening the Emergency and General Internal Medicine Department and continued to work in close collaboration with the Orthopaedic Trauma Department. In addition, she holds a board certification in the fields of internal medicine, emergency medicine, and infectious diseases. The other speaker is Dr. Kenji Tateda, who is an Orthopedic Trauma Department Chief of the JR Sapporo Hospital. Dr. Tateda is originally from Hokkaido, Japan. He graduated from Sapporo Medical School and completed the orthopedic surgery residency training program. He has extensive experience working in several emergency trauma hospitals across the city. His main areas of specialization are hip joint and pediatric orthopedic surgery. In addition, he enjoyed medical education, which is why he is currently the coordinator of the orthopedic residency program at Sapporo Medical School. Ladies and gentlemen, Drs. Kenji and Urara.
Thank you very much for introduction and such a great opportunity. I'm Urara Nagagawa. I'm gonna give a presentation mainly, and it is indeed a great honor to be here. Thank you. By the way, have you ever tried a bullet train or Shinkansen before? Our hospital, JR Hospital, belongs to Hokkaido Railway Company, and the company is famous because they own this Shinkansen. If you have a chance to visit Japan, please try it. Anyway, to talk about infection, we cannot ignore surrounding situation and patient backgrounds. Therefore, let us introduce Japan, Sapporo, a little bit. Sapporo is the 5th biggest city in Japan. The population is almost 2 million. And our hospital located in front of Sapporo Station. Sapporo is famous for beautiful dishes. And if you drive an hour, there is an actual nature there. Especially winter is the best visit. Anyway, 20 minutes presentation is not long enough to introduce Sapporo, Japan. However, we have a huge problem too. Becoming elderly society influences our practice a lot. This is an outline for my presentation today. Talk about elderly society quickly, then let us talk about our hospital, especially about surgical hip repair and AMR, then challenges for AMR and COVID-19. Aging rate in Japan is dramatically increasing. But this is not our country's own problem. America, England, Germany, Western countries, they have chasing behind us. but speed is slower than Japan. Then how about Asian countries? Philippines, India. Some countries' speed is much slower, even slower than Western countries. However, other Asian countries have a more difficult situation. China, Thailand, Korea, Singapore. And in fact, America took 72 years to become 14% from 7%. And even Germany took 40 years. On the other hand, Japan took 24 years. Korea, moreover, took only 18 years. And the aging will affect cause of trauma. This is a data from Japanese database and causes of trauma related death in 2009. And aging leads to increasing proportion of fall down. Majority cause of will switch from a traffic accident to fall down in elderly population. In addition that, beautiful winter and slippery road and delicious alcohol, Sapporo attract people and lots of travelers fall down and break bones, unfortunately. Therefore, hip fracture is one of the most common orthopedic trauma in Sapporo. Then 73 hip fracture repairs were performed last year. The average age was 80. 70% were female. Predictably, elderly patients have lots of comorbidities: angina, CHF, AFib, renal failure, DM, hypertension, dyslipidemia, stroke, cancers, psychiatric disease, and so on. Then some are on steroids. It means they have a quite high risk for surgery sometimes. But complication reports are not that common, fortunately. This minor medical consultation include incidental findings of a tumor or electrolyte abnormalities. Since the number of complication is not big enough, we cannot describe a statistical measure of difference accurately. But when we review patients and divided into 3 groups, uneventful, non-infectious complication, and infectious complication, then review chart retrospectively, and time from injury to surgery seems not that different. And after complications are solved and discharged, the length of hospitalization also seems almost same. However, ADL seems affected by complications. Uneventful patients, their ADL at discharge after discharge were good enough to go back to same atmosphere before they got injuries. However, patients had complications. They tended to need more supports at discharge and transferred to other facilities. Especially who had infectious complications, it seems that they were born with that. So are they caused by AMR? Actually, detected pathogens were not AMR. This table shows an antibiogram of a major gram-negative rods at JR Sapporo Hospital. Talking about E. coli, safe reaction sensitivity 100%, levofloxacin 83%, And even ESBL producing E. coli maintain PAPC tazobactam 100% sensitivity in vitro, but when levofloxacin 0%. Pseudomonas showed a bit of resistance, but a multi-drug resistant pseudomonas was not found last year. Overall, they maintain quite good sensitivity, but a levofloxacin sensitivity tends to be low. Then vancomycin has 100% sensitivity for MRSA. So AMR is not our issue in Japan, is it? The answer is no. We have lots of snowboarders and skiers from around the world. In fact, there is a clinic which prescribes the highest number of crutches in Japan, nearby Sapporo. And all of the clinic staff are capable to communicate in English, because more than 70% of the patients are travelers from overseas over there. This is a figure shows the critical situation that we face. The crisis of the AMR. It is said that 10 million people will die of the AMR in 2050 if we do not take action now. And we need to facilitate cross-border action together, especially Asian countries' cooperation is regarded very important. So let us introduce the challenges in Japan. So for quinolone resistance is one of the biggest problems. And then proportion of the resistant E. coli is increasing. Even though meropenem has good sensitivity right now, we need to maintain it and avoid carbapenem resistance for future. Since we know that once it starts increasing, it will be common quickly. For example, VRE reports increasing in Japan. And MRSA, our enemy in orthopedic field, is an important issue too. So how we can improve this condition and reach the target value? There are only limited researches in improving proportion of resistant bacteria, but this could be a hope. This paper is published by Japanese University in Kobe. The aim of this retrospective study was to evaluate the changes in the following prescription characteristics, trend of oral quinolone use, and antibiotic sensitivity of bacteria over 8 years. They found a significant reduction in unnecessary antibiotic prescription. And during these 8 years, quinolone resistance was dramatically improved. And antibiotic prescription has been reviewed and gradually decreasing in Japan. Quinolone also. And last topic is the challenges for COVID-19. So last year, 73 COVID-19 patients were admitted in JR Sapporo Hospital. Some of them were transferred from the orthopedic department in other facilities. So let me briefly introduce them. So 3 of elderly patients were admitted for respiratory distress. And they were suspected to have pneumonia or pulmonary embolism, but all of them were denied with a CT. And they were found to have difficulty coughing up sputum because of a vertebral pain secondary to laminectomy and compression fracture. And so painkillers solved this kind of a respiratory distress in these cases. A patient developed rash, and which could be drug reaction, but could be one of the symptoms of COVID-19. Anyway, there was no dermatologist over there, and they transferred to us. And there were some asthma attack cases secondary to COVID-19 infection too. So they have some difficulty accepted by COVID-19 units in other facilities because of orthopedic problems. Because usually internal medicine physician and nurses are taking care of COVID-19 in Japan, and they are not familiar with the orthopedic problems. So these multi-problem in several fields are kind of our challenges right now. In addition to that, we also had a difficulty dealing with the diagnosis, and unfortunately, we explained several nosocomial infections in Japan. And PCR is helpful, but it is also known that PCR negative doesn't mean COVID-19 is excluded. And PCR negative, but if COVID-19 patients are well known, and there are several close contact patients too, who can turn to be contagious sometimes during their hospitalization. They tend to be in more difficult situation rather than even a COVID-19 PCR positive patients to receive medical care. This patient in gray zone, a big issue in emergency care right now. And we are ambitious. So we would like to be strong and have a resilience in dealing with such gray zones and multi-medical problems to protect and maintain good quality of orthopedic care. And how can we make our dreams come true? So crossing boards could be one step, isn't it? Collaborate orthopedic doctors and hospitalists, Asian countries and cooperation, and so on. So we go first, not only in becoming elderly society, but achieving there. Thank you very much.
Is Dr. Brigadier General Adrian R. Quidlat. He is an orthopedic trauma surgeon, former ward officer of the Battle Casualty Ward of the V. Luna General Hospital, Armed Forces of the Philippines Medical Center. He was past president of the Philippine Orthopaedic Association, past president of the Philippine Society for the Surgery of Trauma, former commanding officer of the V. Luna General Hospital, Armed Forces of the Philippines Medical Center. He's presently Executive Medical Director, Perpetual Health Medical Center, Las Piñas City, Metro Manila, and also Executive Medical Director, Perpetual Health Medical Center, Biñan City, Laguna. Ladies and gentlemen, Dr. Quidlat.
Thank you, Dr. Sinon. First of all, I would like to thank Dr. Rolando de la Cruz, the chairman of the ASEAN Collaboration for Trauma, and to all the scientific committee members for your invitation to be a part of this webinar. Thank you very much. Thank you, Dr. Urara Nagagawa, for your presentation. Thank you as well for sharing with us the beauty of Hokkaido. I, together with my wife and children, would very much like to visit one day. I hope you are welcome there. As shown in one of the slides, suffering from a fall is the highest cause of trauma-related death in Japan. It is also one of the most common causes of the hip fractures in the elderly. Multiple studies across Asia show an exponential increase in the incidence of hip fractures in the elder age group. Surgical hip fracture repair, or hip surgery, and open fractures may lead to fracture-related infection. Currently, the lack of scientific evidence regarding the diagnosis of fracture-related infection has precluded the development of evidence-based diagnostic criteria. An expert group composed of scientific and medical organizations, the Fracture-Related Infection International Consensus Group, was convened to develop a consensus definition. And this resulted in a definition that was based on two criteria. First criteria is the confirmatory criteria, which infection definitely present. The second criteria is the suggestive criteria, which infection possibly present. On confirmatory criteria is composed of clinical signs and microbiology results. On the clinical signs, fistula, sinus, wound breakdown, purulent drainage, and the presence of pus on the wound site is visible. On microbiology result, pathogenic microorganism identified from at least 2 syphilitic tissue specimens. On suggestive criteria, composed of the clinical signs, laboratory signs, and microbiology results. On the clinical signs are local or systemic signs. That is, local redness, swelling, and systemic sign of fever. There will be also a new onset of joint effusion, and also a persistent, increasing, or new onset wound drainage. The laboratory signs, there is an increase in 3 sero-inflammatory markers, and these are the erythrocyte sedimentation rate, the white blood count, and the C-reactive protein. Microbiology results, pathogenic organism is identified from a single deep tissue specimen. Historically, the Gostillo-Anderson classification of severity of injury in open fracture has been utilized as a predictor of infection. Open fractures have the greatest risk for fracture-related infection. Therefore, on treatment of this fracture-related infection, the use of antibiotics for reducing infection has strong support from numerous studies. Patients with Gostillo-Anderson type 3 open tibial fractures who are given antibiotics at more than 66 minutes or 1 hour after injury are at substantial risk of developing fracture-related infection. There is a moderate support for administering antibiotics as soon as possible after the injury. There is also strong support for recommending the use of first-generation cephalosporin for Gustilo type 1 to type 3 fractures. But there is limited evidence for the additional use of systemic gram-negative coverage in Gustilo-Anderson type 3 fractures to prevent infection. They are giving systemic aminoglycosides, but it may risk nephrotoxicity, especially in the presence of hypertension, renal dysfunction. The current literature moderately supports stopping prophylactic antibiotic after 24 hours in patients with type 1 and type 2 fractures, and 72 hours in patients with type 3 injuries. Continuing antibiotic use for 24 hours after wound closure is supported, but not beyond the time frame, regardless of open fracture type. Antibiotic resistance truly is a global problem. And despite there is being differences in our biograms of our hospitals, the challenge of treating these infections in timely and appropriate manner remains a problem. With that, I'd like to thank again the ASEAN Collaboration for Trauma. Thank you.